Okay, we're reconvening now. We're reconvening. Thanks everybody for coming back. I know that at my table, or said at a couple tables at lunch, people are still kind of humming over, and there's a buzz over the discussion, the panel we had early on today, as well as our speakers, Dr. Hughes and of course Admiral Levine. What we're going to do now is have 4 consecutive brief presentations basically on what works. We've entitled this Best Practices from Patient Advocates. You're going to hear from 4 of them, 2 of whom, by the way, will stay over for the panel that will follow this. So this is basically 4 times no more than 10 minutes. We won't have time for Q&A, but if you have some good questions arising from this, perhaps they'd be appropriate for the panel discussion a little bit right after that. So first up is Scout, and Scout is the Executive Director of the National LGBT Cancer Network, and Scout is going to address cancer support provider training resources. Perfect, since we heard already this morning about the importance of training. Scout.
Thank you, I appreciate it. Is Blaze in the room yet? Blaze? He left. I got my pronouns put on here. And since my clock is probably counting, I should stop doing anything else to get to the actual presentation here. Okay, so the great news is that there's an increasing number of resources that are available for anybody who's in any direct practitioner environment and interested in doing a better job of outreaching to the LGBTQI communities. And just as an example, we are an organization that not only educates our own communities, we train providers all the time these days, and we advocate for mainstream cancer organizations like NCCN and all of the other organizations represented here to do a better job serving us. But a lot of what we also do is we create resources which can, for any of our members, and membership is free, just say you would like to, can be branded with your own logo and disseminated. So imagine us like, in a lot of cases, we're a garden center, but we don't have any land. We sell a lot, actually we give away a lot of kind of tools, and you as practitioners are the people who actually have the land. So we hope that you will take our resources, put your logo on them, make them look like your own resources, because we need to make sure that people, as were so eloquently talked about on that panel just early before lunch, have an understanding that we're welcome in care. And we're going to talk a lot more about these things in the future, but just to also say, I'm the executive director of the National LGBT Cancer Network, a trans guy, and I want to be clear, I am 1 year late for one of my cancer screenings because of my level of aversion to trying to find new providers or going in front of new providers when I have no clue that they're welcoming. So if there's someone as highly educated as me and as highly motivated as me, we need to do a better job of showing people, and I live in a really welcoming state, showing people that it's safe to go in for care and that people like me will be treated with dignity. So with that, let me run on to some of the resources. I think you've seen that guy before. This is what stuff we do. As I had said, membership is free. You can also get on our listserv for free. We encourage you to do so. We got a lot of information about things that are happening in the arena. Last couple of years, it has really been getting to a boil from a slow, slow simmer. We also have an online resource library. We encourage you to give us a bunch of information. If you have anything that reaches to these communities, let us put it up there so everybody doesn't have to reinvent the wheel. With that, so what do we have as patient resources? This is one of my favorite patient advocates, along with Paula, actually from earlier, Daniel Garza. Again, you can take all these things and link to them from your own website. You can put your own brand on it. This is a new thing we just debuted this last year. It is a page to encourage us to understand how tobacco disparities are affecting our population and encouraging us to move forward to actually going to a cessation provider. So again, it gives tailored information as to how this is disproportionately impacting us, which we know is incredibly tied to cancer rates, of course. We also have a whole bunch of promotional things like this to go in your social media feeds. And you see that bottom left corner of all of them? That's waiting for your logo. You can get the Out Proud Free, which is one of our policy change and tobacco control initiatives. You can get those stickers actually right outside of the table. Valeria is here. There you go. Valeria is right there. And she's the one staffing our table with a whole bunch of resources out there. So please go and take as many as possible, and we will send you more for free. We also have the first ever website about trans people with cancer in the United States. And so we're looking to collect more stories about this. And again, this is something you can put on your resource page. One of the things, we recently ran a large survey, 2,700 respondents, queer cancer survivors. One of the things they talked about again and again was no information about sex after cancer. They were getting heteronormative sex, and that did not work for a lot of people. So we also have a new microsite related to what the sex experience is like after cancer. You can link to it, and or you can suggest people who might want to put new stories up. We're really happy that just this last year is one of the biggest cancers, colorectal cancer. We debuted a whole colorectal cancer site, which again, you can see there's shareables, you can put your logo on them, and you can link to this. We're also really happy, as we talked about, we have to diversify the communities who are actually serving us, who are providing us this care. So we're really happy to be working to invest in that early leadership. So if you have anybody who is either LGBTQI and or a person of color, then please encourage them to participate in our diversity pipeline initiative, Cancer Leaders Like Us. And I'm gonna give you a little bit extra space around this one. Also, we're not a direct service provider. We are a systems change organization. But after we saw in that survey how many people talked about needing social support, and it didn't work when they were put in hetero-cis normative social support places, we're like, okay, let's start providing exactly one direct service. These support groups, they meet 3 times a week, every single week of the year, especially through the holidays. And that flyer is, again, not for us. You're the one who have the cancer patients. So please, we encourage you to spread the news that these are free, they're virtual, and it's the kind of resource that has not yet happened in our communities. All right, so with that, what kind of options do we have related to provider trainings? This is also an area that's growing quickly, and I will also say the demand is growing very quickly. We certainly are in a situation where we're dealing with many, many more people outreaching to us saying we really needed to come in to train our providers. And as you'll see in a second, we're also doing a lot of work with 7 of the NCI designated cancer centers specifically in this area. But what kind of resources do you have? Generally, there's a few different things as far as the resources that are available right now, a few different things that you should really know about. Moffitt Cancer Center has colors training. It's currently going through its 2nd round of testing for efficacy, so it's not yet widely available, but they've had some great investment from a lot of LGBTQ researchers in trying to make that a very cutting-edge training, so we're hoping that that one's gonna become widely available very soon. Also, Mandy, who was up here speaking just a little bit earlier, has created the GW Cancer Center's Team SGM training, which is an organizational-based training. One of the things I like about that is that if you just train the people and not the organizations, you're not going to create welcome. So I like the idea of creating that at an organizational level. And you can get a hold of them under Team SGM training. And then we have a few different types of trainings. One of them is that we have just invested, it is about with Society for Gynecologic Oncology, our partner of this. We've invested about $200,000 in creating what we hope is one of the most cutting-edge trainings out there. It currently offers, it's about 7 hours of CE training across all the different disciplines, and it is free at least through the end of this year, and I'm trying to get money to make sure it's free through the end of next year too. So we're gonna be talking about that. That's the Welcoming Spaces training, as you see here. These on the left are the main modules, and these are tuned for anybody who is in the world where they're seeing people who have cancer. So that means from your front desk staff on to your specialist oncologists, everybody should have this information in as a basis for what's happening with our communities. And then, as a special add-on, the last 3 sessions over here are specifically for anybody who's providing trans gyn-onc care. And as if you've ever tried to do that, you'll know that there's very little information in the area. So we really appreciate all of the providers who got together to help us develop information here. One of the things I will say about this is slightly surprising. Huge number of people talked about how excited they were that it was coming out, yet we need to spread the news because we're not having as many people sign up for it as we would have guessed initially. We still have hundreds and hundreds, no question, but we've got thousands and thousands out there that we need to treat, so that we need to make sure have the best level of education. So remember, it is free. Please, please use it. And I don't know if I can play this with the sound. This is an example. Whoops, nope. Let me ask for the people who are running this. Can you hit go on the video here? I have 1 minute and 33 seconds left. 1 minute and 30 seconds.
Among our transgender, gender nonconforming, and racially diverse community members. Discrimination can negatively impact our cancer diagnosis and treatment experience.
Okay, we got a little snippet. All right, we're just gonna call it that because it's 1 minute and 11 seconds left. What it actually talks about is, that's okay, we're fine. That's okay. What it talks about is a woman, a trans woman who goes in and talks about how her care is very different, as Paula experienced too. When she shows up with her male partner, when she shows up with any man in her life, but when she's there alone, she is treated with a level of kind of systemic suspicion, disregard, dismissiveness that we've seen a little bit of it with people's direct experiences here. But unfortunately, it's something that she's become very, very accustomed to. And that's, of course, the kind of thing we want to make sure doesn't exist. Also, after NCI just put out supplemental funding for the NCI-designated cancer centers to collect sexual orientation, gender identity, SOGI data, we're really happy that we're actually working with 7 of the cancer centers and consulting contracts to help them, A, make their agency more welcoming, and B, then collect data, because you'd never want to do B before A exists, right? So just as some examples, these are some of the different types of chapters that we're putting in the trainings that we're building for these different places. Framing it about why we're here. There's some actually, Karen Parker, who's going to be on the panel later, helped bring this into existence. It's a new NASM report on data collection for our communities. And the fact that we suspect that right now we'll get better evidence, but we think about 20 out of the 66 cancer centers, NCI-designated cancer centers, are moving to do this. So that's a big trend. So these are just a couple of the excerpts of the kinds of things that we bring to those providers to give them a little bit of a sense of how our community's experience with cancer is different than the general population. 35 seconds left. Look, at this point, we could go back to the video. No, I'll just call it. That's good. We're going to talk a lot more on the panel. And thank you very much.
Thank you very much, Scott. I hope that you noticed that basically you've got sort of non-proprietary resources. You're inviting folks to take them, please, and put your label on it, right? Right. And that's not a common thing, right? So cheers to that. Next, we're going to hear a little bit about the NCCN clinical practice guidelines and then the patient guidelines. Just if you don't know, people in the cancer policy community point to the NCCN guidelines first, top of list, when making like coverage determinations, health plans, payers, insurers, and so forth. Similarly, with regard to the patient versions of these, if you know the guidelines, you know immediately to point folks to the patient versions. And I'll add one more thing. When you know about these, let's put it this way. I bet there's not a person in this room who hasn't been touched by a family member, friend, or colleague who says, I've got this particular kind of cancer, what do? I tell them, I email them the link to the patient version of the NCCN guideline. So I'll tell you right now that I use this a lot whenever I get a question, and I'm sure a lot of you do as too. This is like highly sought after. Therefore, Tanya Fischer, who's the senior medical writer for the patient information for NCCN, is going to tell you how the patient versions are becoming adapted to this language and the proper way to destigmatize these discussions. Tanya.
Thank you very much. I really appreciate the opportunity to speak. I've really enjoyed being here today. So my name is Tanya Fischer, and I'm here to discuss the respectful and inclusive efforts in the NCCN guidelines for patients. I use she, her pronouns, and as mentioned, I am the senior medical writer for patient information at NCCN. So our best practices, or what I like to call better practices, because I really feel like we're always trying to improve, and who's to say what we do is best? This is just where we are today. So we do use, we're very particular about our language. We choose gender omission. We really go for gender omitted language when possible. But when not, then we are gender inclusive, age sensitive, and non-stigmatizing. We use diverse and inclusive images and illustrations. We're always aware of being respectful, sensitive, and inclusive. Like all these things are running through our minds when we're writing the books. And we solicit feedback through surveys. So the NCCN guidelines for patients are based on the NCCN clinical practice guidelines in oncology. The patient guideline is on the left. The NCCN guidelines are on the right. The NCCN patient guidelines are funded by the NCCN Foundation. And the NCCN Foundation is committed to advancing cancer care so all patients can live better lives. And just a little bit about the NCCN guidelines for patients. We currently have over 65 patient guidelines. They are available free on our website at nccn.org/patients. We also have a free mobile app. There are over 35 translations in 22 languages, and as mentioned before, we do use as users surveys for improvement. So please read our books and submit some feedback. Let us know what you think. This is a list of all of the patient guidelines. Big list. And a screenshot of our website to show the translation and that we have resources for Ukraine, and we also have COVID vaccination guidelines as well. And so now I'm going to talk a little about images. This is an example of some of the diverse and inclusive images we use in the patient guidelines. And this is an example from the adolescent and young adult cancer patient guideline that was recently updated that also includes a diverse and inclusive image with a patient quote. So when considering images, we also think about the relationship of the images with one another on the covers. So in this instance, this is the breast cancer series from 2020, just showing the suite of books, the 3 books, and the various covers, with the updated version in 2022. Again, the suite of books with the relationship of the images to one another. Just making aware that we are trying to reach a diverse audience. But not only we're trying to reach a diverse audience, we are reaching a global audience as well. And so since we have those translations, we do keep these things in mind. Inside the books, we use diverse images of skin color. And as we use non-human skin tones. And so we talked about images, and now we're on to words matter, and really what's essential. This is what is essential to us. It's essential to me. It's essential to us in patient information. So we use person-first language, and you're a person. We literally put the person before the diagnosis. So you're a person or an individual with cancer. You're not a patient. You're a person. You're a person first. It's a priority to use age-sensitive language, so we don't use words like older or younger or senior or elderly. And as mentioned, we opt for gender-omitted language, but when a distinction must be made, we choose sex assigned as birth. So in this example, this is from our bone cancer patient guideline, and it just says that you're a person with cancer. So those with metastatic bone cancer at diagnosis, or in the sticky note, those with bone cancer. So it's a kind of a general term, but doesn't specifically say patient, doesn't specifically point anything out. And then with age-sensitive language, again, under 60 years of age, this is acute myeloid leukemia. You can follow the circled areas to kind of direct your attention. An adolescent and young adult, or AYA with cancer, is a person 15 to 35 years of age at the time of initial cancer diagnosis. So you're a person. We use age ranges. We use under and over instead of older and younger. So I'm showing you another example from acute myeloid leukemia, just showing you the age-sensitive evolution from 2018 to 2022, where in 2018 we say the behavior of AML often differs between older and younger people. to the 2022 version where AML behaves differently in those 60 years of age and over. So non-stigmatizing language, right, age sensitive. And this is an example, again, from Bone Cancer, a recent update, 2023, for gender-omitted language. This is about, as mentioned earlier, fertility and fertility preservation. So we opted in this instance to say those with ovaries, those who can become pregnant, those who menstruate, or those with testicles. You know, it's very difficult to kind of choose which headings to use, but this is what we opted for in this instance. And then there's evolving language again in the breast cancer series. And our language follows the clinical practice guidelines, which has also evolved from men to male to those assigned sex at birth. So you'll find that the patient guidelines, since they're based on the clinical practice guidelines, follow a similar progression. So in breast cancer series 2020, right, anyone can have breast cancer, including men. Although there are some differences between men and women, treatment is very similar, so, right, not great. To the updated version in April 2022, anyone can have breast cancer, including males, getting closer. Although there are some differences between males and females, treatment is very similar for all genders. So that was kind of what we go through rigorous medical review, and you know, the panel, our patient advocates, we all kind of discuss how to word it, and so that was what we chose at that time, to where you have in July, it got better, right? Anyone can develop breast cancer, including those assigned male at birth. Although there are some differences between those assigned male and those assigned female at birth, treatment is very similar for all genders. And so this is just another example from the breast cancer screening and diagnosis. In this instance, we're using gender-inclusive language. We're talking about transgender individuals and those assigned male at birth to draw particular attention to those treatment populations. So these next two slides, I'm kind of asking you to think about this. This is marginal zone lymphoma from 2020, this summer, 2022, where we chose fertility, all sexes. So again, we're trying to draw attention to fertility preservation and fertility issues in everyone. So all sexes was added. To the AYA, right, fertility, all genders. Again, they're both recent updates. It says 2023. It's only because it's based on the 2023 clinical practice guidelines, but it was published recently. So, you know, think about, you might think, well, clearly one's better than the other. But it's kind of interesting that, in particular, the patient advocate preferred all sexes because sex assigned at birth is used throughout the book, so they thought it was more consistent to say all sexes. So what we might think is better, it's just there are always different perspectives, and you're just making the best choice that you can. And so at the end of every book, we have these questions where we're trying to prompt caregivers or those with cancer to ask questions. And so, how many people like me of the same age, gender, and race have you treated? So prompting, right, because these are books, they're passive. So we try to find these ways to prompt people to kind of start the conversation. And as always, there are improvements needed. And so we hope to be better. So thank you very much.
Well, Tanya, thank you very much. I don't know if we planned it this way, and Tennille probably did, but what you said and presented means so much more having heard the panel, because the panel kind of unearthed a lot of issues that you are so well addressing, so attentively addressing in the use of language, and you're sharing with us how this has to continue to evolve. Mm-hmm. What looked good in April may not look so good in July, may not look so good next February. Right. And so the fact that you're paying such close attention to this is really meaningful. And among other things, the person first look, age sensitivity, gender omission, and your thoughtful color palette for representing skin tones in an unbiased way. Very subtle, caught that. Thank you very much. So thanks so much, Tanya.
Thank you
Great,
very much.
you got it, sure. So up next, thank you. We're going to look next at supporting LGBTQIA plus couples with cancer. Couples with cancer, you heard again earlier today about the whole couples issue, who kind of gets to walk in with you or not in the exam room and so forth. This is going to come via a pre-recorded message from Darryl Mitteldorf. Darryl is the executive director and founder of Malecare, and in particular their National LGBT Cancer Project. So let's roll this tape.
Hi, everyone. Thank you for being here today and for listening to this presentation on caring for the LGBT couple facing a cancer diagnosis. I'm Darryl Mitteldorf, an oncology social worker. I'm also the founder of two national organizations, one Malecare, which is focused on gay men and prostate cancer, celebrating its 25th anniversary in March of 2023, and the National LGBT Cancer Project, founded in 2005, the world's first national organization focused on our pride community and cancer survivorship. So today we're going to discuss 3 emotions that you can ease for your LGBTQ patients and clients based on our organization's experience helping over 105,000 people in our support groups during the last 25 years. The 3 emotions that most LGBTQ patients face when seeking healthcare assistance is that they feel scared, they feel alone, and they feel a mistrust of the healthcare provider and the institutions that they both represent and are part of. I think most people in the audience understand what I'm about to say, but to level the playing field, I'll just lay it out that cancer amplifies the loss of power and personal agency throughout LGBTQ life. Cancer affects typically older patients, and that's what our organizations have been focused on. Older adults in the United States have a history of being closeted and stigmatized. They fear the therapies that are offered to them around cancer, particularly hormone therapy, which has a toxic history of being used as a punishment, particularly in the UK. There's an internalized fear of heteronormative institutions in general, but particularly acute regarding healthcare seeking people, since you're seeking life-saving therapies and treatments from an institution that doesn't seem to understand or represent you and your community. And the basic year 2000s theme of coming out to your doc. When is it appropriate? How is it appropriate? Should we tell our doctors and nurses and therapists that we're part of Pride community, or do we keep ourselves in the closet with the goal of ensuring a prejudice-free care opportunity? So let's deal with the first emotion of feeling scared. And that relates to what I just said, feeling fear, feeling scared of engaging with an institution that's been traditionally focused on heterosexual people. Here are some of the basic things that you, your agency, your clinic, your office can do instantly. And that's email and snail mail information about your office and the intake forms that you've already prepared to be LGBTQ cognizant, welcoming, supportive, loving. You should have all the sexual and gender minority opportunities for people identifying themselves. You shouldn't say married, single, or other. Other should never be an option on an intake form. Undoubtedly, it will be there, but you should have many, many more opportunities for people to self-report who they feel they are, who indeed they are, and how they want to be referred to, the obvious pronouns, but particularly for transgender people and people who are fluid or identifying in unique fashion or just out and out queer, they should have the opportunity to state that or to click in a checkout box that you have already pre-filled in with appropriate appropriate language. part of this deal is to be empathic and loving to the people who you are about to meet. And finally, those forms should have an opportunity, an empty paragraph box where a patient can answer, what is their lifestyle like? Do they go out a lot? Do they have many partners? Do they live in fear and live a solitary life? Are they, in polyamorous relationships? Just an open-ended question that allows your patients, your clients, to express themselves before they get to the office. That tells them that your environment is less to be feared than most other heteronormative environments. Second emotion is around feeling alone. Even if your patients and clients come in with a partner, with a friend, with a husband or a wife, they'll undoubtedly, unless you're a gay-focused agency or clinic, they'll undoubtedly be one of the few sexual and gender minority people in the waiting room. The waiting room should be as warm and as friendly as your home living room. And that means reading material that's appropriate for everyone. Have copy of the Advocate, have copies of whatever local newsletters from LGBTQ organizations exist in your communities. Have posters that are not heteronormative exclusively. You could have a man and a woman hugging each other, but you should have a man and a man hugging each other, 3 men hugging each other, 3 women hugging each other. You should have just a variety of imagery, or you should have no imagery at all. You should never have an office environment or a waiting room environment that suggests you're focused on one type of community, typically a heterosexual community. And your resource lists should go beyond American Cancer Society, go beyond cancer care, go beyond NCCN. You should have lists of local LGBT community organizations, and you should have national organizations like LGBTcancer.org and Malecare.org. Your bathroom should be degendered. It's insane that we still have male and female bathrooms. Let everyone use every toilet in your building. People got to go, but they should feel safe in going. Also, gowns. Colors of gowns matter. The way gowns open matter. Figure out what are appropriate gowns for the types of examinations that you have in your clinic or hospital, and have them and offer them. And ask people, like, would you like this or would you like that? Train all staff, practice with them. Get them to feel comfortable with LGBTQ people. And if you have a staff member that doesn't, even if it's a major physician, fire them. You wouldn't tolerate a racist physician or staff member. Do not tolerate a homophobic staff member or physician. All staff should be welcoming and supportive to all patients. Third and final thing, and really the most important thing, I think, is the sense of mistrust. LGBTQ people enter a healthcare providing environment wondering, are they going to be taken care of, both in terms of excellence, in terms of judgment-free consultation, and in terms of appropriate and caring care. They want to feel the love. They want to feel, just like we all do, we want to feel that we're in the arms of somebody who's going to not only take good care of us, but knows something about us in order to take good care of us, and is pointedly fearless in asking us direct and simple questions. What do you specifically need? What are your goals for this treatment? What do you want me to avoid? Many cancer treatments impact sexual quality of life. Many cancer treatments impact ambulatory care and such. You want to ask your patients what their life is like, what their concerns are, and where are the guardrails that they don't want to jump over. And you and your staff may have taken like a cultural literacy course, 2 or 3 hours online or in person. If you're lucky, you did it in grad school around LGBT life. That's not enough. That doesn't clear you for not being further inquisitive with your patients. That doesn't mean you know about their, if a patient says, I'm a gay man and here's my partner and we're here for prostate cancer treatment, or wondering if you can help us around that. Ask. Don't think like, oh, well, I took a course like last year online and I know everything about you. I promise you, if you're heterosexual, you don't know everything about LGBTQ people. And this is an opportunity for you to have a warm and caring conversation with your patients and clients as to what their life goals are like, what their current lifestyle is like, and what their goals for treatment are like. When you see a patient, ask who they're accompanied with. Don't assume that a man and a woman are in a heterosexual relationship. Many people in our community have straight friends who accompany them to healthcare settings. Ask who that person is and go beyond that. Ask who they are in a relationship, if they are in a relationship. Ask who they consider their family, not their mom or their dad necessarily, but who do they look to? Is it, the coffee shop owner that they have developed a relationship with that is almost comparable to parental kind of experience? You want to learn about your patient, but you want to make that patient know that you care. And the way you do that is by asking, by delving, by listening, and by expressing empathy and love, frankly. So I think in a 10 or 15-minute presentation, there's a limit as to what we can cover, but I hope the three emotions that I pointed out to you will be something that incite inquisitiveness and reevaluation on how you and your agency and hospital and clinic have been taking care of your patients. It's worth noting that transgender patients have unique treatment challenges. This audience probably knows that, but just again, to level the playing field, lack of gender-related insurance coverage, difficulty in finding healthcare professionals that have expertise in transgender care. And by the way, expertise rather than experience. Every person that walks into your waiting room, into your clinic, your agency, into your office deserves the finest care available on planet Earth at this very moment and perhaps in the future. So you should be looking to provide them with the best care. And if it's not in your agency, if it's not in your hospital, then help that person seek out whoever is expert in helping them around cancer, and particularly cancer therapies that are unique for all transgender people. And remember, transgender people have different presentations. Some are pre-surgery, some are post-surgery, some are mid-hormone therapy, some are not doing that. You need somebody who's genuinely expert, not just somebody who has a casual understanding. And then basic things like helping people feel safe getting to your office. There are some neighborhoods that just are not safe presenting for transgender people, for anyone really sometimes, but unique to transgender people. You want to help them get from point A to point B with the minimal amount of anxiety of stress. Thank goodness we have Lyft and Uber now. And your clinics and hospitals should be the ones that pay for that. And finally, know that people of color may have issues that trump the issues that face LGBTQ patients, or may run parallel to them. Ask, ask, ask. Find out what barriers being a person of color may present. Find out what barriers they may present between you and the person presenting in your office. You yourself may consider yourself a person of color, but does the person in front of you feel that you're of the same color, or that you look the same or feel the same or understand the same? These are all opportunities for conversations and better treatment discussions that ultimately result in the most optimal shared decision-making opportunities. And I hope that you will take that back to your agencies, to your lives, to your professions, and to your staff and colleagues, and have wonderful discussions on engaging more and more LGBTQ patients and clients in your environment. These are the websites for our organizations, lgbtcancer.org and malecare.org. And I offer you my email, Darryl, D-A-R-R-Y-L, at lgbtcancer.org. Apologies for not being with you in person, but I totally invite you to email me about anything and everything, including collaborations if you'd like to join with us. Thanks very much for your attention.
Okay, big thanks to Darryl, and he very effectively gave us sort of a tripod framework of scared, alone, and mistrust. Starting with those three sort of pillars, he gave very good examples of how they play out and specific things we can do to address those three key concepts, scared, alone, and mistrust. Finally, we've got Sean Cahill is going to come up next. Sean's going to talk about creating affirming and culturally responsive care for LGBTQI plus patients. Sean, welcome. And Sean's going to stick around for the panel as well.
Thank you. Thank you, Dr. Goodman, and thanks, everyone. Let's see here. Okay, so I'm the Director of Health Policy Research at the Fenway Institute, and I'm going to talk about disparities, discrimination, and data, and best practices in cancer prevention with sexual and gender minority patients. So in addition to working at the Fenway Institute, I have a couple of academic appointments, and I also serve on the Massachusetts Special Legislative Commission on LGBT aging. So I'm going to talk about disparities, just touch on it really quickly, and also talk about the impact of discrimination on health and how discrimination can function as a barrier to accessing care. And then I'm going to focus on best practices for culturally responsive care, building on Scout's presentation about materials that we have on our website that you can use. Talk about the importance of data collection and use in terms of clinical decision support and preventive screenings in particular, and then talk about the importance of non-discrimination policies within your healthcare institution as well as in public policy. So we know that there are higher rates of certain risk factors for different kinds of cancer in the LGBTQIA plus community. These include higher rates of tobacco and substance use, higher rates of nulliparity or never giving birth among sexual minority women, behavioral health burden, such as higher rates of substance use, but also higher rates of depression, social anxiety, PTSD, and a lot of that's related to experiences of discrimination and stigma. We also see higher rates of diabetes and higher rates of metabolic syndrome in our community, and that can be a risk factor for certain kinds of cancer. And also higher rates of obesity among sexual minority women. We also have lower rates of preventive screenings, lower rates of breast cancer screening, Pap tests among sexual minority women, transgender men, people on the transgender masculine spectrum. And these intersect with racial ethnic disparities. So Black and Latino women have lower rates of these preventive screenings as well. So those intersectional populations in our community are particularly important for prevention outreach. We also know that there are higher rates of HPV-related cancer, including anal cancer, among gay and bisexual men and transgender women. And gay and bisexual men who have HIV actually have 80 times the rate of HPV-related anal cancer. But unfortunately, only a small minority are vaccinated. And we now have vaccines that are recommended for up to age 45 for both males and females, men and women. And so it's important that we encourage people to get those, particularly gay and bisexual men and trans women. So now talking a bit about discrimination, a recent survey done by the Center for American Progress, a national survey, found that more than 1 in 3 LGBTQ Americans faced discrimination in the past year, and it was over 60% of transgender respondents. 15% of LGBT Americans report postponing or avoiding medical treatment due to discrimination, and it was more than 30% or nearly 30% of transgender individuals. And 69% of those who reported discrimination said that it negatively affected their psychological well-being, and 44% said it negatively affected their physical well-being. So discrimination is a very important public health issue and healthcare access issue. Discrimination also contributes to poverty and lower rates of insurance coverage. So there's a stereotype that the gay community is economically privileged, and some of us are. But on average, LGBT people are actually more likely to be poor than the general public, 22% versus 16%. And the highest rates of poverty are found among bisexual women, transgender people, people of color, and rural people in the United States who are LGBT. During the COVID-19 pandemic, LGBT people experienced twice the rate of food insecurity, according to the U.S. Census Household Pulse Survey that it did that it published actually in August of 2021. And we also know there's other state data from the Behavioral Risk Factor Surveillance System that tell us that there's higher rates of food insecurity prior to the COVID pandemic in our community compared to heterosexual and cisgender people. Lesbians are also less likely to have health insurance and a usual primary care provider compared to straight women. Now, all of the disparities that I'm mentioning intersect with racial, ethnic disparities and racial, ethnic discrimination, as well as sex discrimination. And so racial stigma is a major barrier to care for Black LGBT people, as we heard from Paula this morning with her really compelling personal story of seeking treatment for cancer. And this can contribute to medical mistrust. And there's a lot of reasons why members of our community have medical mistrust. Older people have it related to experiences of maybe being encouraged to get conversion therapy. I have an older friend who went to his college reunion and met a classmate who, when he was in college, confided that he had attraction to other men, and he was subjected to shock therapy, electric shock therapy. This is a guy who's probably 75 years old now. So there's a lot of medical mistrust in our community, particularly among transgender people, older people, people of color, and intersex people. And while the Affordable Care Act has cut the uninsured rate in half in our community, there are still really striking racial and ethnic disparities in insurance coverage, with Hispanics and American Indians, Alaska Natives having the highest rates of uninsurance, followed by Black people and Pacific Islanders. So this is a graphic from the Kaiser Family Foundation. You can check this out. I think it's a little hard to see, but Asian Americans and white people have the lowest rates of uninsurance. Black people are kind of in the middle, and then other groups are higher rates of uninsurance. Okay, so best practices. I think there are three that are important. Culturally responsive care, training staff, collecting and using sexual orientation, gender identity, and sex characteristics data, or SOGISC data, as well as anatomical inventory to inform preventive screenings, clinical decision support, and population health management. And I'll explain that a bit. And also adopting non-discrimination policies in your practice and advocating for non-discrimination language in public policy as well at all levels of government. So this is a website. This is the page of the National LGBTQIA+ Health Education Center, which is a project of the Fenway Institute where I work. And we are funded by the Bureau of Primary Health Care to train health centers around the country who provide care to 30 million people in how to provide responsive, affirming care to LGBTQIA+ people. We have tons of stuff on the website. It's all available for free. We just published a textbook, which you have to actually pay for, on transgender care. We have an annual transgender conference, which you have to pay for. Those are the only two things that you have to pay for. Everything else is free. We have a lot of archived webinars. We have issue briefs. We have a lot of information about how to collect and use SOGI data, how to ask the questions, how to train your staff, overcome their anxieties about asking these questions. So I encourage you to go there. We also use Project ECHO, the Project ECHO model, and we have cohorts of healthcare providers around the country looking at transgender healthcare, promoting PrEP for HIV prevention, and other issues. And then like I said, we do a lot of training on how to ask SOGI or SOGIS questions. So these are the current response options we recommend for sexual orientation. These are the response options we recommend for gender identity. And then these are the options we recommend for sex assigned at birth. And this is all on our website. If you email me, I can send you these slides if you're interested. We also recommend that anatomical inventory be collected and used, as well as pronouns and names. So clinical decision support tools in electronic health records use demographic data as well as lab and ICD-10 codes to make recommendations. But providers have to use their judgment as well and not automatically do what the algorithm is telling them to do. So we know from the National Transgender Survey that most transgender men retain a cervix and are therefore should be encouraged to get a Pap test. But if a patient has had a full hysterectomy, they don't need to get a Pap test. There's also nuances with breast cancer screening for transgender masculine patients. And perhaps they don't need it, but many transgender masculine patients should be screened for breast cancer, even if they've had a total mastectomy. We also recommend collecting and using pronouns and name used, even if they don't match what's on the patient's insurance. And then these data can also allow a healthcare practice to document and monitor disparities in healthcare access, such as accessing preventive cancer screenings, and deploy interventions to try to reduce and eliminate those disparities. So you can, by managing this from a population health perspective, you can say, what's going on with black lesbians and black bisexual women, and how do they compare to black heterosexual women, or to other lesbians of other racial ethnic backgrounds and bisexual women, or what's going on with transgender male patients in terms of Pap tests, and how can we develop interventions to reduce disparities. Or if you're looking at pre-exposure prophylaxis for HIV prevention, we know that there are really striking racial ethnic disparities in vulnerability to HIV among gay and bisexual men and transgender women, with black people at greatest risk and people of Hispanic or Latinx people at also at elevated risk compared to white non-Hispanic people. So are people accessing PrEP at the rates that they should be? And if not, how can you intervene? Same thing with looking at the intersection of preventive cancer screenings for cisgender women and racial ethnic disparities among women in cancer screenings. And then I just wanted to mention the importance of collecting these data in surveillance. The SEER program, the Surveillance Epidemiology and End Results program of the National Cancer Institute, should collect and report SOGI and sex characteristics data in cancer prevalence and outcomes. And also the CDC's National Program of Cancer Registries should require that states collect and report these data. We're all paying taxes, we're funding these systems, and we should be able to get data on what's happening with our populations. The last thing I'll touch on is the importance of non-discrimination. So the federal government under the Obama administration implemented some very strong non-discrimination regulations governing healthcare. Unfortunately, the Trump administration and Republican attorneys general around the country challenged these. The AGs legally challenged them and got gender identity non-discrimination enjoined by a federal court in Texas. And the Trump administration just sort of in a wholesale way rescinded these protections. So they also expanded what we call religious refusal policies, which allow religious healthcare and social service providers to discriminate on the basis of sexual orientation, sex, history of abortion, and religion in providing healthcare and human services. But thankfully, in 2020, the US Supreme Court decided that anti-gay and anti-transgender discrimination in employment are forms of sex discrimination and therefore violate Title VII of the Civil Rights Act of 1964. And so the Biden administration has come in and interpreted this Supreme Court ruling, which is a very positive development, very strong ruling written by a conservative Trump-appointed Supreme Court justice, and said this means that anti-LGBTQI plus discrimination in healthcare violates federal law as well. So they have put out guidance. President Biden put out an executive order on day one of his presidency, and the Office of Civil Rights at Health and Human Services put out guidance saying that it's going to interpret federal prohibition on sex discrimination to include SOGI discrimination. And then there's the Equality Act, which has been stuck in Congress since 1974. Congresswoman Bella Abzug from New York introduced this bill for the first time, and we're still trying to get it passed almost 50 years later. So it's not going to pass this session, unfortunately, and not next session either. The need for these protections is particularly important because at the state level, we're seeing a slew of anti-transgender laws being passed. We've seen it in Florida, Texas, Arkansas, Idaho, and other states, and also religious refusal policies passed. So it's really important for, and this is just some guidance that the Biden administration put out informing state policymakers that federal law trumps state law and that their interpretation of federal sex discrimination prohibits discrimination on the basis of gender identity, which is occurring in many states. But what you can do as providers and as employees of healthcare organizations around the country is, and particularly if you live in a state that doesn't have a SOGI non-discrimination law, which, oops, I can't go backwards, yes I can, which is most of the country, it's about 30 states. So these green states have the laws, but most of the South, most of the Midwest and Plain states don't have these laws, and therefore people are vulnerable to discrimination. Okay, so so what you can do is train your staff on, make sure you have a non-discrimination law, a non-discrimination policy. It's required by the Joint Commission from 11 years ago as part of their accreditation process. But train your staff in what SOGI non-discrimination means and how it plays out in terms of how patients are treated. And this is especially important, as I said, in states without these laws. So I'm going to stop there and I guess invite the panel up. All right.
Thank you very much, Sean. Yes, if our panelists could come on up to the front, and we're going alphabetical left to right as we always do. Sean, Earl, Karen, Scout, and Ryan. Thank you. And as our panelists are coming up, I hope that you did catch Sean's comments about intersectionality, very important. He showed us some really scary stats, if you ask me, on LGBTQIA plus patients. He pointed out the intersectionalities with poverty, food insecurity, and uninsurance and underinsurance. He was rather direct about the issues faced for men with breast cancer, cervical cancer, anal cancer, and how naming and identification messes up screening and care and outcomes. So that was a very helpful discussion. Thank you very much, Sean. Okay, this is our panel. Now that we've identified all of these problems, good gosh, policy solutions, good luck, to advance equitable cancer care for the LGBTQIA plus community. And as we've done before, audience left to right, I'll ask each of our panelists to identify themselves. A few have already, but they can say another word or two if they want. Sean, we think we know why you're here, but reintroduce yourself and say in a sentence or less why you're on this topic, policy.
So you know what my professional affiliations are. I've been doing LGBT rights work, LGBT equality work for more than 30 years, and focused on health for about 15 years, HIV in particular, and LGBT health disparities.
Thank you very much. Next up is Earl.
Hi, my name is Earl Folks. I'm the president and CEO of the Center for Black Equity, which is a Black queer organization dedicated to building our Black community in the United States and globally through the pillars of social equity, health equity, and economic equity. And I'm on this panel because I didn't realize I've been doing this work for as long as I have. I had hair, my beard was black. I've been doing HIV/AIDS and LGBT equal rights work for about, I hate to say 30 years, but since the 90s.
Thank you, Earl, and all the interesting background that goes with it. Thank you. Karen.
Hi, my name is Karen Parker. My pronouns are she and her, and I serve as director of the Sexual and Gender Minority Research Office at the National Institutes of Health within the Office of the Director. And I've been with that office since it was stood up in 2015. And I do a lot of work with the Department of Health and Human Services and with federal colleagues across the United States government.
Karen, what's your building over there? Everybody's got a building number in range, right?
I've had several over the past 7 years, and now our entire office went virtual.
Oh, you did?
So
okay.
we're all working from home
Building V now.
full time.
Yes.
That's right.
Thank you. Familiar with the campus for many years.
Yeah, yeah.
Thanks, Karen. And Scott, what else do you want to tell us, Scott?
I've been doing queer health policy since the Clinton administration, since back when Earl had hair. And why? Because that is the way we're going to make the biggest system changes to actually create street-level changes so that our community is more welcome.
Thank you, Scott. And over to Ryan.
Yeah, hi, I'm Ryan Wilson. I use he, him pronouns. I am an RN care coordinator at the University of Minnesota Masonic Cancer Clinic. And I am here today kind kind of representing the Oncology Nursing Society. We have a focus group on LGBTQ plus advocacy efforts and policy and legislation efforts to create better systems for people with cancer.
And you're doing some special programming in the spring about it.
Yes, yep.
All right, good, very good, thank you. I'm reminded, by the way, at the end of our session today, somebody or somebodies may have a few items in the lost and found, we'll call it that, including some earbuds and another characteristic item or two. So when we're done today, if you think you may have lost something, please go to our registration desk. Thank you. With regard to policy challenges, I know that, Sean, you kind of led us off on that. And just I'm going to return you for a bit on this, Sean Cahill. What are the top 1 or 2 policy challenges facing these communities today? We liked your state map, that was very helpful, but if you could just enumerate the top few of those, what are the big ones insofar as discrete, explicit policy challenges?
I think non-discrimination is the most important one.
Okay.
To be able to put a roof over your head and food on the table, you need to be able to get a job and earn money. And the fact that we don't have protections in many states makes it difficult for people, I think, to do that. So that's one issue. I'd say the other one is probably the rise of white supremacist, racist, anti-Semitic hate violence. That affects our community. It's connected to anti-LGBT hate violence. It doesn't necessarily hit. It affects everybody, because hate violence has that chilling effect that you're being singled out because of a characteristic.
Well, let me ask you then about that, because I asked about policies,
yeah,
and you laid some of that out.
Yeah,
and
but I think there's a policy angle.
Okay, that's what I want.
Well,
then you went to hate and violence. What policies are relevant there?
Well, I think, a lot of it's happening through social media, through high tech, all this new high tech stuff that we have. And a lot of political manipulation has been happening here and in Brazil and other countries through YouTube, the algorithms of YouTube and Facebook and all these things. And I think there needs to be greater regulation. And I don't think that the First Amendment means that people should be able to put out racist and anti-Semitic hate on social media. I don't think that's protected. That should be protected. Okay. I think there's a way to regulate it.
How about Second Amendment?
Well, that's, yeah, we put out an issue brief right after the massacre in Orlando, I guess in 2016, about gun violence as an LGBT health issue, because we have higher rates of suicidal ideation, right? Suicidal attempts. If you attempt suicide with a gun, it's much more likely to work, and you're much more likely to die. So that's one angle, but it's also hate violence.
Yeah. Thank you, Sean. Glad you came up with that.
Like we just saw in Colorado.
Unfortunately, yes. Scout on the policy, on the discriminatory laws issue, Ryan, Earl, on these issues in order.
In a word?
In order.
Oh, got it. Okay, got it. I was like, wow, that's
Ryan,
a challenge. Okay, good.
A few words. We'll give you a few words.
3. I really think that it's important to know, if you're not in the queer communities, that we feel like we are in a hailstorm of anti-LGBTQI legislation right now. It is just a popcorn effect going on around the country. Like, as we get news in our inboxes, we hear about the library in Florida that instead of carrying LGBTQI information, they're going to close the whole library down. So it's like, it's a world that makes no sense, but it feels as if from every angle and every place, we are ducking and running from kind of these, constant arrows coming at us. There's a new record level of anti-queer legislation in every legislative session for about 6 years now. So there were almost 270 bills introduced in March alone of this year, and that wasn't even when the legislative session was over. Wow. So we feel in the middle of a storm of negativity. And the second thing I really will say is that this lack of data collection we talk about is not just a lack, it's a systematic erasure. Because as we think about places like NIH, which funds most of eliminating health disparity research around the country, how are we supposed to be competitive with NIH applications if we don't have the same level of data that other populations do? We are creative, but we cannot create things up out of empty rooms. So that's the thing that is not just a lack. It's unfortunately one of our biggest things holding us back from identifying and fixing any of our health disparities.
So data-related policies. I must say that I'm kind of taking notes on phrases I haven't heard before, but that I love, one of which is now, unfortunately, systematic erasure. That's a great way of capturing the downside of that data issue. Ryan, I hope you can speak up a little bit, and you might talk about maybe Family Medical Leave Act. Do you have an angle on that?
Yeah, so as a care coordinator, I'm constantly trying to advocate for patients to access the care that they need. And a cancer journey, a lot of times, isn't journeyed alone. You oftentimes need caregiver support in order to successfully go through a lot of the really challenging treatments that are associated with cancer care. And right now, FMLA is only protected for caregivers that are either a spouse, a child, or a parent. And so there should be a more expanded definition of what a caregiver can be, because people of the LGBTQ community oftentimes have chosen families. And while they might not be biological families, they are still important family support structures that help people get through these cancer therapies. And so there are some states that do protect caregiver rights and have more expanded definitions for caregivers, but really we need more broad federal legislation to protect these people.
That's so helpful, and I frankly, had you said that to me a day ago, I would have said, yeah. But now I kind of get that if we have only those, I think you said spouse, child, parent. Well, not everybody is one of those things. And so by the terminology alone, folks are excluded, which has implications for talking about my problems and the care that I need and the care that I receive.
Yeah, and when we talk about policies, sometimes there are those unintended consequences of policies, and this is just one of those examples. I think the policy itself is well-intentioned, but there needs to be, people can lose their jobs because they don't have time away from work to be able to care for their loved one who's going through cancer care.
Thank you, that's a great angle. So, Earl, you shared with us how long you've been doing this with the Center for Black Equity, and certainly you have seen changes too fast or too slow in policies, and I'm just wondering what you're facing now insofar as any particular discriminatory laws that you see right in our faces now.
Well, it's interesting. I find the whole environment of discrimination laws, as a black person, African American, this is something we've been living with since the last 400 years. And so I think that, especially considering that most African Americans who are queer live in African American neighborhoods, we're dealing with the same issues that African Americans are dealing with: lack of transportation, lack of living in food deserts, a lack of access to cancer clinics, appropriately trained staff, all the things that queer people are dealing with, black people have been dealing with for 400 years. And I think that there needs to be a better alignment, a better intersectionality of black issues and queer issues so we can get both our balls across the finish line. Discrimination, we're losing our right to vote, we're losing so many rights that we thought were always institutionalized and would be around forever. We're starting to lose that. At the same time, as a black gay man, I'm trying to push my issues, which are very similar to black people's issues, and we need to work together. So the lack of appropriately trained staff who can, and having cancer clinics in black neighborhoods, which is something that's very rare that you ever find, speaking to my colleagues around the country. We could do a better job of aligning issues around race and sexual orientation, and sexual identity.
Earl, you suggest that there's been, albeit some progression, certainly some regression in recent years with regard to discrimination and related laws. Can you give us some notion or specifics or an example about how the regression along the lines of discrimination has affected the community?
Well, it's even hard to paint that picture. The fact of the matter is that things have not changed for black queer people in this country. We technically have the right to marry, but the right to marry is about protecting property. And if you don't have anything to protect, it's not, for many people, it's not helpful, it doesn't do anything. And I think that, and as I'm saying this, I'm running through my mind, the situations of people who I know who had cancer, and the problems, including my own sister, who had breast cancer, the things she had to deal with were things that, as a gay activist and living in a certain neighborhood in Southwest DC, I don't have to deal with. It's about access to the institutions that are there, many of them are positive, many of them have dealt with LGBT issues very affirmatively. But if you don't have access to those spaces, then you're stuck in the same situation.
Earl, is it true that being a black transgender person is one of the most hazardous population groups in the country?
Woman.
Black transgender
Woman.
Woman, even
Right.
more specific.
Most definitely. Again, most transgender women of color, as black women of color, live in black neighborhoods. To get to a safe space, they have to fight their way out of their neighborhood. So as a black trans woman, I know black trans women who, when they decide that they're going to the corner to get a carton of milk, they have to determine if it's safe enough for them to walk that one block, or to walk that several blocks to the bus, or standing waiting for the bus on a summer day or summer evening, or just going across town. I don't have to think about those things when I walk out my door, but as a black trans woman, they have to think about their safety issues. Are they going to make it back home? Are they going to make it to the destination safely? And almost every day an incident occurs. Someone says something snide or something that reminds them they're not safe. Just the way they're treated in the bus, they're treated in the store, everywhere the destination, they are reminded that they're in danger and their lives are in danger.
And if their lives are in danger that way, it's much tougher, I guess, to try to think about how to get to a clinic and get screened.
It's low priority. That's why we lack in pap smears and preventative care and even post-diagnosis care, because the danger.
Literally the danger of getting from point A to point B.
And is it worth your life?
Okay. Good gosh.
Just on that point,
Yes, Scott.
we just had Trans Day of Remembrance. That's when we unfortunately memorialized the people who have been murdered the prior year for being trans. And if you're familiar with that list, first of all, a notable point is there's usually more people on that list than there are on all of the other hate crime murders for all of the other associated populations that experience hate crimes. But that list is every year almost exclusively black and brown trans women. So the risk there is inconceivable.
It is a most threatened population group. Karen Parker, the National Institutes of Health is primarily a research agency. We wonder what angle a research agency, in particular through your outfit, what connection that has to policy or even discriminatory policy.
Well, most of the policy that I think about in my work is really related to things like SOGI data, and then of course some like NIH-wide policies, where I'll say there are still many NIH policies. Scout could probably give you a long list.
Hold on.
I also have that list written down. But things that one of the reasons our office was established was really to look across the agency and say, where are there barriers to conducting this research at NIH? And then how can we work with our colleagues to remove those barriers? I'll say things in government oftentimes move slowly. And so we have made much progress, but there's so much more work to be done. We have made a lot of progress, as Scott pointed out in his remarks, on SOGI data. And so right now, under this current administration, SOGI data is sort of exploding across not just HHS, but many other agencies. And so we are working on an interagency working group right now on SOGI data. There was an executive order put out in June of 22 that called for a subgroup of the Equitable data working group that would focus on SOGI. That group has been meeting. A report is forthcoming. As a part of that executive order, the Office of Management and Budget will be putting out best practices in SOGI data collection, hopefully informed by the Nason report that NIH funded. And then finally, part of that executive order is to require every government agency to do SOGI data action plans. And so we are sort of in the depths right now of developing what those action plans need to look like. And so we're hoping that that type of sort of push from an executive order will help not just at some of the, I would say, more obvious spaces like in HHS, but also at places like, for example, Department of Homeland Security, right? Looking across Department of Ed, all of these other sorts of spaces where we know SOGI data collection should be collected as a part of basic demographics.
So I want to go to a particular area of SOGI data collection. Again, NIH is the world leader in sponsoring clinical trials. Can you tell us a little bit about the presence or absence of SOGI data in clinical trials of new therapies? Is there an upside and a downside there?
Well, certainly there is not much data collection happening within clinical trials, particularly when you think about, areas of research where people might not think like, oh, it really wouldn't matter to have that information. That happens a lot, I think, within cancer. And so one of the things our office is trying to do is to make sure that people sort of realize that we need to collect this data in all of the work that NIH is doing. And so, whether it's diabetes or cancer or heart disease, we need to be able not just to collect the data, but also to analyze the data and to report on the data so that we can start to see patterns where are there differences. And that's, I think, one way that we'll really be able to move the field forward. We are funding a fair amount of SGM-related research. It will never be enough, and we will continue to try to grow our research portfolio in SGM health. But
Say what SGM is?
Sexual and gender minority health. We need to really not just grow that specific portfolio, but we need to make sure that the entire portfolio that is looking at human health is thinking about sexual orientation, gender identity, sex characteristics, and really truly looking at that data to figure out sort of where are there challenges and where do we need to develop specific interventions.
So this is very helpful and important. So Sean and Earl, what are the implications, do you think, of the lack of SOGI data in clinical trials and new therapies? Sean, then Earl, perhaps?
Yeah. If you don't count us, we don't count. That's the slogan we used in Albany to advocate for state agencies in New York to collect SOGI data like 10 years ago. And it's really true. If you don't collect data on us, then we don't count. So, for example, COVID-19. We are not collecting data in COVID-19 testing, vaccination, or treatment. So we have no idea what's happening with the LGBT community.
Wait, even now we're not?
Even now.
Nope.
We've been pushing for 3 years, and we've
California.
made no progress with the federal government, unfortunately. The CDC case report form for COVID-19 just says, what's your sex, male or female? That's it. There's no gender identity question, there's no sexual, and there's a racial ethnic question, there's a age. So other demographics are collected, but yeah, it just means that we don't have data, the most basic information on what's happening with our community. The Fenway Institute, where I work, we were involved with one of the COVID vaccine clinical trials and with the monoclonal antibodies trial, and half of our patients are LGBTQ+, but we didn't ask, in the research projects, we didn't ask SOGI questions, so it's a real missed opportunity.
And
Earl?
the only place that's collecting SOGI information on COVID-19, I believe, is California.
Yeah, there's a few states, yes.
But again, to Sean's point, if you don't exist, if you don't get counted, you don't exist. And I've been doing this work for 30 years, and I was told the dollars follow the data. So if you don't exist,
dollars follow the data?
right?
Yeah.
So if you don't exist, then you're not going to get any dollars. You're not going to get any money to do the work that's needed in the community.
So if you don't count us, we don't count, and then therefore the dollars follow the data, but they're not going to follow the absence of data. The dollars aren't going to follow to the people that need them.
Yes.
So Earl, can you explain a little bit more about how the absence of SOGI data in clinical trials may have an impact on the black community?
Well, the problem with that scenario is that we finally get counted racially, but the other part of who you are, half of who you are, or whatever percentage of who you are, doesn't get counted. So the racial part helps, but if it comes to dealing with the LGBTQ part of your life, especially in getting treatments for cancer or any other disease, and resources in the community, which is so you don't have to travel 10 miles or 100 miles to get something done, it's not going to take place. So you can, just because you're black doesn't mean that if you go to any kind of black minority institution, you're going to be treated well if you're LGBTQ. Matter of fact, there's a lot of homophobia in some of the institutions that serve the black community. And so again, do you go to that local place that's going to treat you horribly, or do you find a way to get across town that takes 2 hours each way to get across town to get treatment that is going to be more appropriate for you being a black LGBTQ person? Those are hard decisions, and what happens is people don't make those, they just don't go anywhere.
So if you are that black transgender woman and you're thinking about going across town, there's a big high hurdle to walking out your front door to do it.
You're stuck between a rock and a hard place.
All right. Scout, on this issue of data, clinical trials, and the absence therein.
Yeah, just a few points. First of all, also, race and ethnicity data is pretty new to clinical trials. I mean, like COVID is one of the first places we saw that reported out, so that's still at a nascent level. We still need to work on all those things. I would say there are some promising moves because as Karen's talking about kind of the explosion in interest in this, we're also seeing it in a lot of the agencies that are doing the clinical trials. We still have to fix some structural things, like, for example, you can't even report if someone's trans right now in the NIH clinical trial database, so structural things need to happen behind the scenes. But on the other hand, we're being contacted by probably 6 pharma companies in the last year talking about how to diversify their own clinical trial work. And I know that one of them, a major one, is on the cusp of announcing that they will be doing SOGI, not intersex, but at least SOGI, data collection on all their clinical trials in the future. So we really are seeing a pretty big shift in interest in this. We just need to follow it up with actual action. The other piece, and as was mentioned a little bit here, is that we're seeing some very similar data collection initiatives happen across the states. So we've got the state of Pennsylvania, the state of Rhode Island, the state of New York, the state of California, and Illinois are often legislatively passing laws requiring this SOGI data collection in health instances. They're still in the implementation phase, but again, this is all part of a big wave that's breaking across the country. But I would also say that as we talk about policy, let's just remember, the legislative wins are few and far between. I've worked probably my whole adult career, and I can count on one hand any legislative wins we've had for LGBTQ people. So when I think policy, and I think when a lot of us think policy, we're really thinking administrative. So like if a cancer center decides to collect SOGI data collection and require cultural humility training for their providers, that is the policy win. That's the ground that we're working on right now. This is not waiting for your lawmakers to do something. This is what are your administrative policies.
Well, thanks. With that, it sets up Ryan nicely because, Ryan, I'm just asking you insofar as in a clinical setting, with the electronic health record and staffing administrative policies, where does this feed in and where does the improvement, potential improvement lie?
Yeah, well, a lot of electronic health records offer options for people to fill out these surveys, at the comfort of their own home or in their own private space without having to actually be asked by personnel. Though, if there are institutions that are using personnel to collect these data, a lot of times clinical trials might actually have a person that's asking them these questions. It's important for those people to be competent and to ask these questions in an affirming way that is inviting and welcoming and creates a sense of belonging for these.
Are we there yet?
I don't think that we are there yet. Maybe the panelists
Scout
could say, but
In
I
my
don't
dreams, we are. But
yeah, so I think that it's important that we use that lens because you can get erroneous data if somebody tells you, something not about themselves or something different from themselves because they're afraid of what might happen if they do disclose who they are or where they come from.
Once again, fear arises. So, Karen, back to, once again, you're among the point people, if not the point person, on making this happen at the world's largest biomedical research agency. So where next on this? We're talking about clinical trials, registries, electronic health records, which are a huge place for data capture. Is there a future here for getting the policy and regs right on SOGI and related data collection?
Well, we're working on that. And I will say, we are sort of a coordinating office, and so we have colleagues across the entire agency who are very committed to this work. I think one important policy, actually I had a side conversation with Mandy after the earlier panel this morning about, she told a story that she heard from someone that a leader at a very large cancer center said, well, we don't collect that data because all NIH cares about is male or female. So you can imagine how that made me feel. And that goes back to the clinical trials inclusion enrollment tables that Scout mentioned, right? So this is something that we have been talking about a lot at NIH. So for those of you who don't know, anybody who's conducting a clinical trial in their application has to put planned enrollment, and so that is required by race and ethnicity and by either sex or gender, whichever you choose, and it's binary. And so that is really problematic, particularly as the agency over the years has been putting out more funding opportunity announcements that, for example, specifically call out trans, gender diverse, and intersex populations. So a researcher wants to do this work, they go to put in their enrollment tables, which is required, and now what do I do? Like, I have to insert people into boxes where they don't belong. And I don't think anybody feels particularly good about that. And so we are working on that specific policy to say, how can we update those enrollment tables, which are now sort of a part of, required by law. So we have to have these planned enrollment tables. So how can we help to get those updated in a way where people can meaningfully and accurately capture their study population? So that's like an example of a real barrier to folks who are doing this work. And then also for people who aren't necessarily sort of enmeshed in this kind of research, but people at cancer centers, for example, who now are making assumptions that all NIH cares about is this sort of binary sex or binary gender construction in cancer research, which is not what we want folks to be thinking.
What you said just reminded me, and in analogous hard-hitting cases in heart disease in women, because for many years, women were not enrolled in clinical trials of drugs and other interventions for screening prevention, screening, diagnosis, and treatment of heart disease. And we didn't even understand how women experience heart attacks and other events differently than the white male populations that tended to be enrolled in those trials. So it sounds as though there's almost an analogous situation here where if we don't have the data on the real people, we're not going to have the findings upon which to base screening, diagnosis, and treatment. So we're missing stuff we don't even know about, it sounds like.
Yes, that's exactly the point. And of course, the enrollment tables go back to this exact issue that you bring up, right? So the enrollment tables began because they were saying that people needed to include women in clinical trials, which is how this sort of started. That's also when the Office of Research on Women's Health at NIH began. And I'll just say a lot of these challenges also go back to the language that we're using, right? So the fact that we have an Office of Research on Women's Health is great, but the conversation we're constantly having is, so what do you mean by women? And how are you defining that? And how are you talking about that? And how are you communicating about that? Because it's very easy for people to feel erased or to actually be erased in programs that are being put out by, whether it's the federal government or a cancer center. So really thinking deeply about language and what is it that you mean to say, and are you talking about sex or are you talking about gender? Right? Those are real challenges. Even almost every presentation I give at NIH, and it's a lot of presentations, we start with some basic language to make sure that people are on the same page. And there's oftentimes confusion, and we still will find materials at NIH where people will say like sex/gender as if those things are just interchangeable. And so I just think being very mindful about how we speak and what words we use, either when we're chatting with people or in forms and those kinds of instances, is really critical.
And you're in a good place to do something about that, but NIH is such an expansive organization. There's the Office of Women's Health, but throughout the NIH, these things need to be taken up. So Scout, just fill us a little bit more on SOGI data and electronic health records. Just want to make sure we nail
So
that.
if anybody has Epic, if anybody has Cerner, any of those places, you're going to have a built-in SOGI data module. The problem is most of the organizations hide that and or don't flip the switch to turn it on in the first place. So like I said, we're working with 7 of the different NCI cancer centers now, but one of the important things about how to do this data collection is you can't start with data collection, because if you're going to ask me if I'm trans, before you show me that I'm safe, being trans, that is you asking me something vulnerable and risky before you have taken the smallest modicum of step to show me that it might be okay for me to disclose that. So, one of the powerful things I think about the idea that potentially, I think 20 of the cancer centers out of 66 from the NCI designated ones are moving on SOGI data collection. I mean, we're in the fine weeds of like how you get the screens in the right place, how you get people actually to be in a safe place to disclose it. But before we're doing that, we're also at the same time saying, okay, what are you doing on your website? What are you doing in your built environment? What are you doing in your personal interactions so that before you ask me, I have some sense that it's okay to disclose? And just to also say, as we talk about clinical trials, in the same way with clinical trials, we don't just want the data. We want people like me and the other people to feel safe enrolling, getting to, and in the way we might be treated. The truth is, for many of us, we've had such negative experiences in the healthcare system. As was talked about earlier, actually, I was reminded my very first cancer screening, it took me 2 days to recover from, because when I disclosed that I was queer, they were not gentle, and it hurt. So if that is our history, then the point is you need to show us that there's some reason for us to actually want to volunteer for extra health interactions, So this idea, data is really important to changing our field. But also, data is a route to examine how welcoming are you? And do you have the pronouns on your badges like we see more and more in hospitals these days? I think that pronouns are actually one of the most powerful new superhero measures we have, because it doesn't say that you're queer. It simply says you acknowledge that some people in the community you care about, of treating everybody well, have experienced extreme discrimination by a presumption over what their pronouns are, things like that. Yep. And you don't have to be part of the community to say easily, I care about making sure I do not perpetuate this level of discrimination. And you can just do it by putting a pin on your badge.
Excellent point. Sean on this, and then I'm going to ask you a follow-up. Go ahead, Sean.
Okay. I just want to say a couple of things about SOGI data collection and EHR, electronic health records, EHRs. It's actually a big success story. A lot's been happening over the last almost decade now. So in 2015, the Office of the National Coordinator of Health IT included SOGI in the Meaningful Use program and said, if you want to participate in the Meaningful Use program, a certified EHR technology has to have SOGI fields. And that made it kind of like the standard for a lot of the big EHR software companies. And that program is now called Promoting Interoperability, Meaningful Use. Also in 2016, the Health Center Network, which provides care to 30 million patients across the country, 1,400 sites, the Bureau of Primary Healthcare said health centers have to have SOGI, have to collect SOGI data and report de-identified data to the Bureau of Primary Healthcare every year, and they're doing that. There's this thing called the Healthcare Equality Index, which the Human Rights Campaign runs, and they have like 700 hospitals, many of them really big medical centers that are collecting and using SOGI. The California University Hospital System, all of them are collecting and using SOGI. So there's a lot happening, and it's really, really good.
So there are good models out there.
Yes.
Some folks are doing it well, but so many aren't, and some of those aren't even trying, unfortunately. So much work, and you're agreeing, I guess, Scout, much work needs to be done. Very interesting question here about encouraging policies for data collection, trials, and registries. That was recognized. The second part of this question, though, I think hasn't arisen yet, and that is, what about in publications like the leading medical and clinical journals and so forth? What about their policies for using the right terminology? And the person says, journals to include trans, gender expansive data, people with DSD, VFC, and should there be policies that call for the right terminology and reject submissions if they don't have the right terminology? I'm just recalling now that there are consortia of leading medical journals that have standards for how you report, for example, clinical trials and so forth, and that has helped standardize and raise the level of quality. But is that a kind of a good venue upon which to sort of encourage the use of proper terminology in the research literature and so forth?
I think so. I mean, I'm in the process of publishing 2 papers, one in a cardiology journal, one in a nephrology journal, on disparities from the BRFSS data on disparities we see in LGBT populations. And they're coming back to us and questioning, like we submitted something that was looking at LGBT people because with transgender people, we didn't find a disparity, but we did with LGBT people. And they came back to us and said, what about transgender people? So there's a lot of people now who are editors, who are volunteer editors of these journals, who are questioning and saying, why are you not being more inclusive?
That could be such a good point of leverage, because if the leading peer-reviewed journals in medicine and science insist upon this, then it gets codified into our body of knowledge. And so, Karen, your people want to probably hear about that too, I would think.
Yeah, I was just going to say, we were just talking about this and thinking about how we need to connect with the National Library of Medicine and talk about how NIH, we don't control medical journals, but we can certainly have conversations.
Well, you help fund the research that ultimately goes in the journals, right?
So we can sort of connect with folks and start talking about some of these challenges, and that's something we were literally just this past month talking about the need to do and to think about sort of what is the way that we can address that without sort of a lot of real power over those.
Got it. Thank you.
Journals.
I will
Yeah.
say a little note related to this is that actually, as a lot of LGBTQI researchers experience, one of our biggest challenges is we submit things to journals and they get back to us and say, this is too small a population actually for it to be important. So aside from the fact the population is actually growing hugely right now, but it means that we're really challenged to get to those journals in the first place. And one of the things also, if you're interested in this area, I would also point out that the Gay and Lesbian Alliance Against Defamation, GLAAD, has a glossary of how to use terms, press advisement that would work as well for research, and they have an expanded section related to health as of this last iteration. So that's a good resource to know.
Point well taken, thank you. And by the way, when they say the population is too small, it sounds like maybe the population is under-recognized.
We actually, through most of my adult life, the level of queers in the population have been 4%. And over the last decade or so, we've moved up to 7.1%. And if you look at the youngest adults, it's 1 out of 5. At this current rate of change, I kept going with building the chart out, by about 2052, we'll be 100% queer. And by 2062, we'll be 200% queer. So I hope they fix math by then.
For those of you who are alive.
Right, I know, I gotta take our B12 shots, right, Earl?
Trying to think ahead, thank you. In a moment, I'm going to ask, this is kind of putting something on deck, about the White House call to action. And I'm going to want to go to Earl and Sean certainly on that, and probably all the rest of you as well, but just kind of a heads up on that. Very interesting question here. We've got some wonderfully practical questions. This is originally directed to Karen because it mentions NCI, but I want to ask it more broadly. It's basically saying when people have call-in lines, like information lines, cancer information lines, or any kind of phone interaction service that you might have, or for that matter, via the internet, what's the protocol for whether, and if so, the right way to ask callers about their identity? So the example given here was the NCI information line. Does it collect SOGI data? Does it ask about it when people call in? Should you ask about it? Should you not? Do you wait for the call to initiate it? Sean, do you have a thought on that?
Yeah, I think what you do is you say, we're going to ask you some demographic questions. We do this for the following reasons to ensure health equity. And then you say these are voluntary questions. You don't have to respond. And we're going to, and maybe say something about what you're going to do with the data. You're not going to share the data widely. You're going to, it's going to keep it. So if you kind of put that kind of caveat language in there, I think people, if they want to answer the questions, they'll answer it, and if they don't, they won't. But I think it's perfectly appropriate. I mean, LGBTQI plus people experience disparities in cancer and cancer risk behaviors, and it makes sense. And those intersect with racial, ethnic, and other disparities.
Well, one reason the question came up is that the person had in mind that an information line is often the first point of contact.
Right.
And if there's a perceived barrier at the first point of contact, your further contacts are going to be eroded, if at all.
And
right?
it's a missed opportunity not to ask the question.
Okay,
And also,
Earl.
it depends on how you respond, who's talking, the tone they use, and all those other things. If you're, you're having a pleasant conversation, and you say, by the way, I have some questions that I'd like to ask you. It's not personal, it's so we can get this information, blah, 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 blah. People are more likely to give it to you if you're being very businesslike and very dry. It's at the interaction with the person. You'd be surprised how many people call, and because they're nicer, okay, I'll do your survey.
Uh-oh, oh my gosh. Okay,
So,
Karen.
I used to work at the National Cancer Institute, but it's been a while. And I'm not sure if the Cancer Information Service asks any demographic data, actually, when people call. I think what really needs to happen is that CIS tends to connect people with resources, both online and like print materials. And what really needs to happen is that all of the materials need to be inclusive, right? In the words that they're using and the images and all of those kinds of things. And so not just for the LGBTQI plus community, right, but for sort of many different communities, all of America and globally, sure, because we also, we're an international space when you think about who comes, for example, to the clinical center and where we fund research. And so I think that I'm not sure they ask any demographic questions. I think they try to connect people to clinical trials and to resources about specific cancers.
Well, point well taken. I would say it sounds as though, when I'm thinking what Tanya Fischer said and what Darryl Mitteldorf said on video, insofar as there being good models for how to prepare those materials to which a caller might be referred. So point well taken, thank you. The White House. So we're at 14th Street. We're like at 14th and F, yeah? We're two blocks away from the White House right now. The White House recently put out a call to action on food insecurity and diet-related diseases toward reducing disparities in underserved communities. Is this White House call to action on the right path, and can it have an impact? Sean, Scout, Ryan, for starters. Back to Earl then.
Yeah, I think it's great, and I think we need more data on how these issues play out in our community, but we have some indications that, like I said, there's high rates of diabetes. Lauren Beach is a researcher at Northwestern who's found high rates among sexual minority men and women. She's also found high rates of sedentary behavior among lesbian, gay, and bisexual youth. More likely to develop type 2 diabetes, engage in less physical activity, more likely to be obese compared to heterosexual youth from the Youth Risk Behavior Survey. Buying and questioning youth spend 30 minutes more a day in sedentary activity than heterosexual counterparts. This could be related to violence victimization, bullying. They might be less likely to go out at recess or on the playground.
Well, as Earl pointed out, don't even leave the house.
They might be less likely to participate in sports. Right now, there's all these anti-transgender sports policies being adopted around the country. And that's, it's really important that young people be able to participate in athletics and for so many reasons, the physical benefits, but the mental health benefits, the socialization benefits. So yeah, there's definitely a lot of indication. And then the high rates of poverty, less likely to be able to put food on the table or get to the end of the month with the money that they have coming in. We saw that in behavioral risk factor data for Massachusetts, comparing LGBT people 50 to 75 compared to straight cisgender people. And so all those are reasons to indicate that it's possible that there's food insecurity disparities and maybe healthy food disparities, food, I don't know about food deserts, but definitely issues related to, eating foods that lower your risk for cancer that indicate overall health.
So there's even the lack of food or the lack of right food can have an impact on cancer patients, particular forms of cancer especially. Ryan, on this issue with regard to the White House call to action on those matters of food insecurity and diet-related diseases, anything to add?
Yeah, I would just say from more of a clinical perspective, people with cancer and those that go through cancer treatments often have some sort of diet modifications that happen as a result of the cancer treatment themselves, particularly those that are treated by surgery or radiation, and sometimes even different chemotherapies or systemic therapies.
Can you give us a few examples about how those work?
One example would be somebody with esophageal cancer that may have to have their esophagus removed and their stomach brought up. That person is going to have a very particular diet that they have to follow as a result of that. Or some people's cancers secrete different hormones that may impact their diet and what they are able to eat. And so I think in terms of this White House call to action, The more diversified ability for people to have access to a bunch of different types of foods is most important for people that are being treated with cancer. And those that are in areas where there is food insecurity are at higher risk for having poorer outcomes, because nutrition is a foundational part of cancer care, and part of what I do as a care coordinator is help people get access to those foods when they're not able to access them themselves. And so, I think that any policy that's able to get people access to food that they need as a result of their cancer treatment is important.
Are you seeing the related impact of the intersectionality of this? I mean, all these things kind of add up. If you're, as we said, if you're Black, if you're transgender, if you're a transgender woman, if you live in certain neighborhoods as opposed to others, and there's no food, and you don't want to leave the house, and you've got this form of cancer, another form of cancer, and or comorbidities like diabetes, that ain't great for your lifespan, right?
Well, right, and I would also add that when you think about food shelters or places where people can access food for free, a lot of the times those may be sponsored by a religious institution, and those aren't always the most welcoming places for people of the LGBTQ community. And so,
Wait, how not welcoming? I mean, there's a table, there's a food, there's a box, you hand it to somebody, right? Or
right, but all under the guise of like a religious, call to help serve people. And sometimes people from the LGBTQ community may have had traumatic experiences in a religious institution that avert them away from wanting to access food at those particular places.
Like for many years, the Salvation Army wouldn't treat trans people, or wouldn't accept trans people.
Exactly.
Yeah.
wouldn't accept as,
To serve trans people in all their services.
you mean those people with the bell in the
With the
pot
bell,
and
yeah,
the Christmas time
exactly,
thing?
Right.
Well, it may be well-intentioned. There are like actual barriers to accessing, like, you're not allowed to be here. And then there's also social barriers saying, I have a traumatic experience with this institution, and I don't feel comfortable going there and asking them for help.
That cannot help a person with cancer who has food-related risks, correct?
All right.
Okay, Scout, did you want to add to this point?
Well, I just want to back this up a little bit and talk about how handy that strategic point is for changing policy. Again, most of our wins aren't legislative. So the White House putting out a series of these kind of executive orders from like day one of the administration. They put out the Racial Equity Plus order that every single part of the government needed to have a plan related to this. They put out the Data Equity executive order where now all parts of government have to have data equity plans that is specifically looking at SOGI data particularly. So this is an amazing tool that you can deploy in your institution, because what you get from on high in any institution sets the character and the tone and the tenor of what people actually care about, lean into, and what they fix or they ignore.
Thank you. So Earl, back to you on the White House call to action. Anything you want to add with regard to food insecurity or diet-related conditions and the potential impact thereof?
I'm going to try to be very careful in my choosing my words.
That's okay. You're among friends.
But I don't know about out there.
Right, the cameras, those tiny cameras.
Okay, smart man.
I'm very politically active. I'm a member. I'm the LGBTQ caucus chair of the Democratic National Committee. I love when the White House is in certain hands. I'm always concerned when the term is up and those presidential fiats are taken off the table. This is great. This is great news for the next 2 years. We need to have a system that's better, that institutionalizes these things permanently, so we're not taking a step back and then take a step forward, and a step back and a step forward. We've been doing this since 2000. We're not getting to the place where we really need to be, because we're still addressing the same issues over and over again. And we need to have a better system that makes these things, a call to action for food, it can't be just for 2 years. It has to be for 20 years. It takes years to reverse the food deserts and the food banks, and make those food banks more appropriate for people to get food, because those food banks are subsidized by the government in many cases. And even those food banks that are not welcoming to transgender women and men, they're receiving money and funds and government support and Department of Agricultural foods and stuff. We need to have a system where we're not issuing fiats every 2 or 3 years and saying the same thing over and over again. That's all I have to say.
So true.
You are judicious and specific in your remarks, Mr. Folks. Thank you. All right, we're about to get a little less judicious. Give Earl a break here. Scott. So, Scott, you saw some maps this morning that Dora Hughes put up about where the centers are and where the people are. And you might have seen, if you're paying attention to Sean's maps, and a lot of different shadings of those maps that kind of change from border of a state to the next border of a state. We're still in the policy realm here, Scout. So what are you seeing and feeling these days on policies from, let's say, governors in certain states and or certain political factions? Is this an encouraging or a more troubling policy environment in which to bring about some of the changes that we were hearing about today, people would like to see?
Let me be very clear. Again, I've worked in this area for a number of decades. It is the most troubling. Absolutely. We are at an unprecedented level of policy attacks, of boldness related to, policies related to, voter rights, related to racism, related to, as we talk about the administration changes, CDC and all the rest of the government was prohibited from doing anything that talked about racial discrimination at the tail end of the last administration. And that meant that I'm part of 8 health disparity networks that are funded for cancer and tobacco by CDC. And we were all told we could not do the kinds of trainings that we usually do because we couldn't mention these things because it was suddenly prohibited. So you add that on with the anti-LGBTQI attacks around the country, and we are in a situation that I never envisioned that I would see in my lifetime because of the level of backsliding. The one thing I will say that gives me hope, despite this backsliding, are those numbers of how many youth, especially young adults and youth, are identifying as queer. Mm-hmm. And I hate to say it, but I think these policies are a backlash against that. There's a lot of people who are like, uh-oh, the world as I knew it, whether it was, Andy, what is it?
Griffin.
Andy Griffith, yes, exactly. The Andy Griffith show.
Mayberry.
Mayberry RFD.
Mayberry.
So Mayberry's gone, and I'm freaked out. I better pass a law to bring back Mayberry. Well, it's not going to bring back Mayberry, right?
Mayberry
sorry, but that
existed.
ship sailed. So the number of people who feel like it's okay to come out in this increasingly hostile world gives me a lot of hope and encourages all of us to take our vitamins to make sure we can watch the change come about.
Thank you, Scott. So, Sean, the policy ether that we're breathing, how you feel about it?
I think we're in a very problematic time as a country for the last 6 or so years, and I hope that we're coming out of it. I'll just mention 2 things, I guess. One is, data collection is so important, and interestingly, it hasn't really been politicized until recently. And unfortunately, this year we saw Florida, Idaho, and Colorado pull out of the Youth Risk Behavior Survey. And they didn't give reasons why, but I really believe that in the case of Florida in particular, with all the anti-LGBT youth stuff and the anti-transgender policies that the state government is pushing there, it's probably related to the fact that they were starting to ask SOGI questions on the Youth Risk Behavior Survey, which is a survey of high school students, that asks about all these risk behaviors that put you at risk for cancer and other health conditions. So it's critically important data. So that's really unfortunate. But I also wanted to mention, I think, Earl, you might have mentioned something about permanency and the importance of permanency. And Karen is an incredible champion for this work as a career civil servant. And one of the things that I know happened in 2015 that I think you were involved with was the designation of sexual and gender minority people as a priority population or health disparities population, right? And that's great, thankfully, a permanent designation that it would take an act of Congress to overturn. And I think that that's one of the things that even if we get a hostile administration, a lot of good work can continue to happen, as was the case from 2017 to 2020.
May I also add a little policy note? Each of you can make a difference in whether or not your state collects YRBS and or behavioral risk factor surveillance system data. Because the
YRBS?
state Youth Risk Behavior Survey. So these are the 2 largest sample size surveys in the country. So if you want information on Black, bisexual males, you go to one of these two data systems. But the states are very open to hearing from stakeholders. And gosh sakes, if you especially work for a medical system, extra open to hearing from stakeholders. So call your states. I call every state behavioral risk factor surveillance system coordinator every single year, because it's optional whether that group of people collects the SOGI add-on or not. Again, intersex is not yet there. With the YRBS, again, it's optional for them whether they pick it up. So you can call the state and make a difference as to whether or not your state actually stays the course and continues to collect this, or like New Hampshire, starts to collect it.
Got it, thank you. I want to bring forward a question from the earlier session today. I promised that we would do that on the U.S. Preventive Services Task Force. We call it the USPSTF. They are an independent panel of expert clinicians, mostly primary care clinicians. They are managed by the Agency for Healthcare Research and Quality, but they are independent. And as I think folks know, they come out with evidence-based guidelines on preventive services, mammography, prostate cancer screening, and so forth and so on. And you also may know that when the USPSTF gives an A or B rating for a certain screening procedure, that has a domino effect on not just government-funded insurance, including Medicare, but commercial insurers as well. So they're like a big deal. The question is, can anyone address the role of the U.S. Preventive Services Task Force in influencing healthcare policies, particularly in prostate cancer screening for men in high-risk categories for prostate cancer? There's some pushback on that group from the HIM Act and HR 1176, used by Zero Prostate Cancer. There has been some controversy about how the populations at risk are identified and described and what data are available. This is a pivotal group. I don't know if anyone is prepared to kind of comment on the USPSTF and its role here, but they can be pivotal on policies. Anything to add on that?
I will say a small
Scott?
point that I want us to actually look at, as I believe was talked about earlier. When you have long-term HIV infection, it doesn't clear HPV, which is a high cancer risk factor, in the same way. And we're now looking at a greater group of people, which highly overlaps with men who have sex with men, trans women, bi folks, and especially people of color as well, black folks, all those sorts of groups that have now had HIV for a decade or longer and are being managed. And it's so adjacent to what you're asking about, because I want to point out that only one state in the country even has clinical guidelines to do anal cancer screening for long-term HIV survivors. That's New York State. And as was talked about, screenings.
Yes.
So no one's getting it. So we are talking with these survivors, and literally, like for example, I was talking with one in New Hampshire the other day. He talked about how he went to his provider and he said, you know, I've got problems, and not only do the providers often think, well, that's because of your sex life, so, you know, don't talk to me about that. We keep hearing that. But second of all, the providers don't even know how to do an anal pap smear. And they don't know
They're
that
not trained?
they have no clue what it is. I'm sorry to say. We literally have so many providers who are like, I'm sorry, I don't understand what that is. And we have evidence from, I believe it's the Anchor study, one of the long-term NIH studies, that finding this early means that something that can be a devastating cancer can be remediated and managed, and survivorship is so much higher. Rates of this cancer are going like this right now. It's a rare cancer, but rates of it are going like this because of those long-term HIV survivors. And we have no protocol to teach the providers. A, you should screen, particularly for this population. B, this is how you screen. So we have some real big missed opportunities related to protocol omissions.
Well, these have to be picked up, though, Scout and others, by groups that do the authoritative guidelines that, like the U.S. Preventive Services Task Force, NCCN, ASCO, I mean, there are public and private sector guideline groups that say that they're evidence-based. If they don't provide guidance on this,
Can someone please just copy New York State? Please, just, I'll send it to you, copy it, put it out as national, because you're much more authoritative than we are.
Got it. Okay, we just have a few minutes left here. We got to some, but not all the questions. Here we are in the policy environment now. This time we're going to start with Ryan, go audience right to left on this thing. So, Ryan, if you could pull a magic lever in the policy environment today, And to Earl's point, it could be an executive order, but he told us about the dangers of that, or it could be a change in the law, or heck, even a change in, heck, I don't know, the Bill of Rights for that matter. If you could pull a magic lever on a policy, whether it's national or state level, that could give us a leap in the ability to address these acute needs of the LGBTQIA+ community. Policy now, what would your magic lever do?
It would be, as I alluded to in the beginning, that whoever the person identifies as their primary caregiver is able to be their primary caregiver. That work and other social aspects of their life do not inhibit them from being able to provide the care to their loved one that their loved one needs in order to survive. Because a lot of the time, these are people that are completely debilitated, and in some cases don't even qualify for certain treatments unless you have a caregiver, like bone marrow transplant or some CAR T therapies.
So identifying that primary caregiver.
So identifying a primary caregiver, and that primary caregiver having the latitude to be a primary caregiver.
Oh, and got to give them the latitude to do it. Okay, that's one. Thank you. Scott, you go up next.
I talked about how I'm a year late on one of my cancer screenings. I would love to just pull a magic lever so that every single place that I looked at, they had something that was trans affirming, and I felt more comfortable going there, including the fact that they did data collection. We talk about data collection for its research value a lot, but another key value is you're showing me, as long as it doesn't ask foolish questions, that you care about me. So it has value as far as demonstrating welcome as well. So I wish everybody had that, and not just myself, but as we talked about the trickle-up effect, Black trans women could see that they were welcomed in every single place that they went. Because if we can do it well for them, we can do it excellently for the rest of us.
Thank you, Scout. Karen, your magic lever does what?
Well, so I'm a career employee, so I'm not going to talk about
Magic's not part.
specific. We don't deal in magic, and I don't talk a lot about
Give us what you can.
Specific policies. But I would just reiterate for the 100th time how important SOGI data is. And then I would just sort of say that in general, as we think about what's happening across the country, anything that inhibits someone from participating in research, from being their authentic self in research, anything that contributes to mistrust of the biomedical research enterprise is really something that's going to be problematic if we want to move forward research on sexual and gender minority health.
Thank you. Well said, safely said, and appropriately said. Thank you. Earl, over to you for what lever you want to pull, sir.
I would say passing the Equality Act.
Yeah.
Right.
I think that would be very key. It sends a very strong message to everyone.
That would get the point across, Earl. Thank
Yes, it
you.
would.
Well stated. Sean?
I would say it would be thinking, what does patient-centered care mean for LGBTQI+ patients? What does it mean for Scout? What does it mean for Paula, who we heard from this morning? What does it mean for Earl, right? And if you think of the work through that frame, then you make these critical changes happen. Culturally responsive and affirming care, non-discriminatory care, and SOGI data collection used to improve quality of care. If you think of patient-centered care and what it means for an LGBT patient, you will do those three critical things.
That
Also,
is
precision medicine, too, another key component. You would still get to that same outcome thinking, we're not all the same.
Yep.
really like that trifecta there, those three elements. Precision medicine, not a bad add-on as well. Thank you. As Gary Waymuller approaches the podium, I just want to point out in closing, I'm going to ask our panelists just to stay put. If you kind of think of where we started this morning at 9:20 and hearing from Dr. Hughes and then Admiral Levine and so forth, we got into our presentations and our panels. I don't know about you, but I'm having trouble absorbing all the information we got today. I'm kind of still processing it. There are some acute messages here about terminology, about data, about environment, about questioning each other, providing safe environments. Some things are tough to get around, but we don't have safe enough environments here. This is all heightened, and the heat is turned up, it sounds like, from the current policy and civil environment. It ain't any better out there these days. And so these are some highly sensitive and important issues. And I think that if you were interested in policy solutions for these, once again, you could not have done better than Sean Cahill, Earl Folks, Karen Parker, Scout, and Ryan Wilson. Please join me in thanking them all.
Oops. I just want to back up a second. Okay. So I have to say that this policy summit has probably been, in my 9 years or so at NCCN, one of the best policy summits that have ever taken place. There's so much energy in this room. And I just want to, I'm glad you gave yourself a round of applause, because I wanted to thank everybody in this room and everybody virtually who has participated for being here today. I think this has been an exciting topic. It's been a controversial topic, and it's one that's long overdue to have been discussed in a forum like this. So I'm really glad that this has happened today. I just wanted to quickly thank all of our panel members, both from this afternoon and from this morning, for being a part of this. Your participation has been so appreciated, and we really enjoyed having you. I will repeat, at the risk of repeating myself, I want to thank our moderator, Cliff Goodman, who I also always refer to as the often imitated but never duplicated Cliff Goodman. So thank you, Cliff, for being with us today. I also want to thank the staff of NCCN that have been involved in organizing this program today, especially our policy department led by Alyssa Schatz, who limped in here with her broken foot today. So Alyssa, thank you. Our meetings team led by Mark Geisler and his capable staff, and our marketing team and business development teams led by Jen Treadwell and Beth Gaffney. They've done a really, really great job of putting this together. And I will echo Dr. Koh's comments from this morning about Tennille Carter. Tennille, where are you? Tennille, who's brought this all together today, and thank you for making this such a great program. I also, if I can get this to advance, also wanted to quickly thank all of the organizations that have sponsored this policy summit. We really do appreciate your support, and we couldn't do this without you. Thank you very much for your support in making this day possible. So before I conclude, there are a couple, I couldn't get off the podium here without making a commercial about a few things we're going to do in the future. We have upcoming in February our 2023 Breast Cancer Congress that will be held live and in person in Chicago and also virtually. If you're interested, there's a link on our website that you could register for that. In addition, and we're really excited about this, our annual conference for 2023 is taking place live and in person in Orlando, and it will be at a new location, the World Center Marriott in Orlando. It's going to be held March 31st through April 2nd, and we hope to see many of you, if not all of you there, if possible. So that's coming up. And then lastly, I just wanted to comment on some of the upcoming policy summits that we're going to be having in 2023 in June, September, and December. And you can see on the screen there the titles of what some of those policy summits are going to cover. So if we have a track record like this, the future policy summits are going to be just as exciting, so hope to see many of you there, either in person or virtually. And so realizing the only thing that stands between you and your plane or your train or your car to get out of here. Thank you all again for coming and participating, and we really appreciate your attention and attendance today, and be safe, travel safe, and thanks again.